Bom, boa noite a todos.
Well, good evening, everybody. Welcome to one more webinar of the Brazilian Journal of Anesthesiology. I am thankful for your attention, for your presence, for one more opportunity of discussing a relevant subject matter that was approached by our publication recently. Our focus in these webinars is to have a chance to discuss a few of the more recent papers published in the publication and to establish a form of interaction between researchers that contribute very strongly to the journal, reviewers and anesthesiologists in general. I remind you that this is a translated in real time towards English so that we have the chance to interact with our colleagues from all over the world, all over the globe. And it's a way for us to spread news about our journal. We all know that we are always looking to improve improvements in quality. You had last month, we know that we were moving towards another impact factor. So this webinar is a way to celebrate this and a way for the journal to interact with everyone and to spread how much the journal has invested on quality and to turn the journal, all journals are all the papers and the journal to make it a way for us to discuss how much we can apply a bit of the science that is published in our journal every day for anesthesiologists. Specifically, the subject that will be approached we reached today is a subject that everybody knows the importance and will have special attention to an edition, a special edition that we will publish next year. Pediatric anesthesiology. So we'll have special attention to pediatric anesthesiology, and we will have a new call for papers, a new opportunity, first opportunity for the journal to work on this focus, specific focus. So the journal launches its call for papers. So our colleagues in anesthesiology from Brazil, as well as outside the country, can contribute to focusing on papers or based on anesthesiology. So I remind you all that this is a special edition. We know that in a certain way, it can be a way to spread a specific subject, increases the visibility of these papers that are made by a special edition. They see more downloads and they also have more citations. So it's a way for us to have a focused edition of a relevant subject matter and that our colleagues can contribute with their research. Specifically, for the subject or guest editor, the editor that will be responsible for managing this special edition is the moderator for today, Vinicius. Então, was an associate editor of the Brazilian Journal and this is Geology of the Clinics, Hospital de University of São Paulo.
Desse rapaz, o Vinícius, que realmente contribui de maneira fora de série, de maneira extraordinária com a
very extraordinary partner to the journal, an incredible scientist. It's very critical and something that I value highly. This is what we want in the journal. We want a colleague that can assess these papers very well and which are the papers that will contribute to the journal and contribute to clinical research. So please, Vinicius, go ahead. I pass the word to you. Thank you, Andre. Thank you for the invitation to be part of this webinar. So, it's always great to be part of the activities of the Brazilian Journal. I'm as a member, as in some form of the publication during the last 5 years. And really for me, whatever involves the journal always makes me very happy. It's a way for me to contribute to the Brazilian Society of Anesthesiology. So for this webinar, we will be discussing 2 recent papers of the Brazilian Journal of Anesthesiology on pre-anesthetic medication on children and pre-anesthesia medication on a very specific population, which is very challenging for anesthesiologists, which is patients with autism. So how can we improve the pre-op approach for kids with this medication, especially kids and grown-ups with autism, improving this pre-anesthesia experience for patients? So to discuss this subject, we invite Dr. Bruna Klauck. I'm very proud of having Bruna here in this webinar because Bruna was our fellow in pediatric anesthesia in the USP University last year, first class. And recently, Bruna came back to us. Now she is one of our assistants on the Children's and Teenagers Institute and the University of Medicine of the USP. And Bruna, she did her residence in Sao Paulo here. And today, practically 90% of our acting is for pediatric anesthesia. So we are quite happy and satisfied in seeing that really the training that she had as a fellow, dedicating a year to pediatric anesthesia, she now can have a clinical practice on clinical assistance of anesthesia. Almost 100% of pediatric anesthesia. You know, it's very difficult to do so in Brazil because most of our hospitals are general hospitals. So Bruna will be discussing pre-anesthesia medication, focusing on the paper, which is a randomized trial for Brazilian colleagues, and the editorial as well that was written by Brazilian colleagues that is also signing a systematic revision of Brazilian colleagues. So 3 publications on this subject matter that really shows the importance of this subject and also shows how concerned we are with this subject matter, and that's why we are producing science and we are publishing this in our journal. So Bruna will be discussing this, and if he has any questions, you have the Q&A. We can discuss with you, and it will be great to answer whatever question you may have. So Bruna, if you would go ahead, you can go ahead and start your class. At the end, we'll have the questions and answers. Okay, everybody, good evening. I will share my screen. Before anything else, I wanted to thank Ignatius for the invitation. It's an honor for me to be part of the webinar and society, be able to contribute to the knowledge in some way, in the same way that I had the chance to do so, to have this knowledge. So on my R3, we had webinars from society, and it was a very positive change. So because since these are recorded, it's an easy access of the knowledge that we have, and it's always up to date. So it's a great pleasure to be part of this today with you.
E o enfoque, então, principal
Main focus
dessa aula seria o editorial,
of this
então
class will be
agora
the
da quinta
editorial
edição da
in the
Brasileira
last
Journal of
edition of the
Anesthesiology.
Brazilian Journal of Anesthesiology, which is
Vai
a,
ser a combinação dos
the question is if it's a
anfetamínicos e
combination
ketamina como
of
pré-anestésico,
ketamines and
seria uma
oral
prática
ketamines, and
segura e
anesthesia will be
efetiva.
a effective and safe practice.
Para começar, eu queria dizer que eu não tenho nenhum conflito de
Well,
interesse.
first off, I have no conflict of interests,
Vou começar
and I will speak a bit about the principles of medication on children. The goals of medication is to reduce anxiety, to avoid physiological stress, block autonomous reflexes, produce amnesia, ease of anesthesia condition, and move and have analgesic effects. Keep in mind what we need to keep in mind to pick the right medication will be the age of the child, their weight, as well as the ideal weight and the real weight, any illnesses or surgical conditions. So what is the surgery is happening, a large scale or small scale surgery, MRI, the medications that they're on, and their allergies, the expectations that the parents have. The parents said that, okay, the kid is very anxious, and if they have had a difficult history, need to keep this in mind. the emotional maturity of the child. So what is the stage of development they're on, their personality, anxiety level, whether they're cooperative or not, their physical and physiological state, and collateral effects as well as possible interactions among medications that are being used. So type of application that we use is the oral application. You also have the chance of using it through nasally, anal access, and as well as oral, IV, or muscle. And it will depend on the state and available research. So orally will depend on how comparative this kid is. These are the kids that will not even drink cough syrup. These days we have midazolam as a syrup. It's tolerable to children, and but you need some sort of cop. They need to be agreeable. If it's a child that does not accept this, we will not be able to apply it nasally. It's quite horrible. But it works because it really has a quick access, and it reaches a high concentration to the issues that we do not have a specific applicator in every single hospital, especially because of a single access type. So it's a bit limiting. Remember that nasally, we have the risk of neurotoxicity due to going for the plaque, so it can have direct neurotoxicity of midazolam and ketamines. And intramuscular, which is what we use more for children that are not cooperating, that are struggling and they're extremely anxious. So in a certain way, we manage to hide this from them. Yeah, we can. It's just a bit of it's just an injection, a shot, and they sort of calm down, they'll calm them down, and we can progress towards actual anesthesia. About the main medication that we use is we have to use midazolam, which is the most widely used from what I understand in my practice, what I've seen. It's as quick, it's quick to take effect, and also quick to go away. The effect that involves dialysis and a moderate sedation that diminishes recall of pre-anesthetic events. So they'll forget that when they're pre-op room, they may forget things that is sort of a retrograde amnesia. It's safe in low doses. It causes minimal breathing depression and very few physiological changes. So usually this is done in a nursing room, especially from non-monitored children here in Brazil. That happens, and the kids are fine. The idea is there should be at least somebody keeping an eye on the child, but sometimes you don't have anybody watching them. So for doses, intra IV, we have 0.025 to 0.1 milligrams per kilo intramuscular, 0.2 milligrams per kilo, and then intranasally we have 0.2 and 1 milligram per kilo. Ketamines, which is dissociative anesthesia, it's very safe because it preserves the muscular tonus and it's particularly stable. So good option for you have cardiopathy or any changes in stability. The disadvantage that it can cause chorea, nystagmus, hallucinations, nightmares. There's still reports of hallucinations, nightmares, and delirium. The idea is that it's reduced to sertraline. So whenever you have ketamines before has a pre-anesthesia, you will associate mirtazapine 0.022 so that it won't bother when placing tubes. Hallucinations, they can be reduced with the use of diazepam. So that's what we're going to be speaking about as well. So for administration of ketamine, you can do this orally. It's a scary dose, which is 2 to 10 milligrams per kilo, but ketamines end up not being absorbed. So 11% is actually absorbed intestinally. That's why you use a higher dose. With that intranasally, 10 milligrams per kilo or from 2 to 10 milligrams per kilo, depending on what we want to reach sedation for this patient. And alpha-2 agonist, it has a sedative effect that is dependent And what we utilize is the dexmedetomidine. The advantages that they have is that they maintain the breathing, they reduce the induction anesthesia, and it reduces post-operatory pain and can be used on EPA. So it actually acts as an aid for analgesia. And the advantage is that they have a prolonged risk of action. So this ends up making it so that we use less of it, use less anesthesia, especially dexmedetomidine, which lasts dexmedetomidine, which lasts for an hour and a half to take effect. We also have not a lot of access to the applicator, nasal applicator. So it's a solution that is not very, let's say, solution with glucose or any other sort of syrup or micrograms per kilo in the time of action, 60 to 90 minutes, and dexmedetomidine, oral dexmedetomidine, or intranasal. So that's the dosage, 2 to 4 micrograms per kilo. It'll last for 20 to 40 minutes. And the question is, we have the ideal medication. We see that all of them have their advantages, but all of them have some point of disadvantage as well. So not yet. We do not have medication that would sort of be of use to every child, and we be able to have a good pre-medication 100% of the time. So the available medications right now, they still leave a lot to be desired when they're used on their own. To not a good application, Dazzalone. So 60 to 40% of patients, a lot of the time, we may have lateral effects to this child that will be, you'll end up with a more agitated child. It can happen 30% of the times. Accommodation is low effect, low speed of effect. Instead of mean, we have diarrhea and hallucinations. So that's why we will see our editorial. This is the importance of the editorial. Let's say if there is an effective practice, there any revision of our recent articles. And we came to the conclusion that yes, it is safe. The association is safe for midazolam, what ketamine is. And the goal of the association is the analgesic properties of ketamine and analysis from midazolam. And with that, we have one of the more pronounced effects of the medication. We use more in a more isolated way. The collateral effects end up being reduced, and they are not altered, and it is safe. So it does not alter the time of permanence or the hospital stay. It's good for patients that have a high rate of sedation. We have very anxious patients, any sort of neuropathic issues, any sort of disability, or anybody that has autism. So the recommended dosage would be to mix ketamines on midazolam VO of syrup and dosage, be 0.25 to 0.35 micrograms per kilo. And for ketamines, 1 to 6 milligrams per kilo, usually they're being 3 milligrams per kilo. So about pre-operational anxiety, it's nerves apprehension that the children will present or adults as well. And it happens 40, 60% of children. So it's highly prevalent. It's important to consider it can happen because of separation anxiety or a fear of losing control or uncertainty on the surgery of anesthesia. If they're be able to remember or feel pain, all of these symptoms depend on the age of the child. Younger kids don't want to leave their parents, and teenagers, they end up having uncertainties about anesthesia, whether they're going to make it or not, whether it will hurt or not. So we need to wait on this when we have free anesthetic anxiety, and the higher stretch moments that we see are we get separated from the children and can no longer enter the operating room, and then for anesthesia induction. So those are ones that are more difficult for children. And remember that this is the beneficial when indicated, but it must be weighed as a routine action. It must be because it depends on the resources. Sometimes it's going to depend on somebody is going to keep an eye on this child. Are they medicated? They'll have to stay So will have resources may not belong to the hospital. We need to weigh risks and benefits. So see where the child will have potential benefit. So what happens when it's have pre-op anxiety? So the behavior of a very scared child that is having taking deep breaths, they're not going to be playing or speaking. They may be crying. So they may try to run away. So we really need to, they may be saying, yeah, I want to leave, I want to leave. On top of behavioral alteration, we have endocrinal changes, increase in adrenaline, increase on the adrenocortical, and basically all this changes your immunity, your arterial pressure, several factors that are important. So it's important to, this is something that will have a reverberant effect if we want to identify this, work on this. The risk factors for the real development when kids that are more than 5 years of age. So autistic children, children that may have had bad prior experiences, kids that are always in the hospital, they end up having a higher risk.
Também acaba sendo gatilho, porque é ambiente barulhento,
And
desconhecido.
they're afraid of the unknown. There are several people wearing masks. That's a noticeable trigger. And another important risk factor is the individual capacity for kids to deal with their own emotions. So kids that are naturally anxious, they have this history. And kids that are emotionally mature, they have lesser risks. And more mature kids have less risk of having this problem. That emotional state of the caretakers also matters. So anxious parents will make kids more anxious. And what we must do is try to gain the trust of children, use humor, try to talk about things that are not related to surgery specifically, and try to integrate, like, in what's going on, not just dealing with the procedures, but trying to actually get them involved in what is actually going on,
E aqui tem
you
a
know?
escala de
So
Hale,
this is the
tá?
scale of modified scale
Ansiedade pré-operatória. É uma
for
escala
pre-op anxiety. It's a bit of a
que a gente
higher
utiliza
scale,
todas as
but
vezes, mas eu achei legal de
this is
colocar
something
aqui,
that we
né?
use a
Porque ela
lot, and
mostra
see that it's nice to
uma
show
boa
out this
noção do
because it
nível
gives you a
de
good
evolução,
idea.
né? Então, ela é dividida
So
em
it is divided in
cinco domínios.
five
A
domains,
primeira é atividade,
because
como a
one of
criança
the first one is
está
activity,
apresentando,
and
então,
how what is the kid doing? Are they looking around? Are they playing? Are they joking? If it's a child that does not play around, if they're quiet, or to keeping eyes on, or this is a kid that is moving in a strange way, or they're trying to get away. We need to keep attention on this, and we'll be able to see whether they're reading or they're doing anything that is right for age, where they are asking questions or commenting things, or they participating in what's going on. If they only answer with whispers, whether they speak, have baby speak, or they're mumbling, or they're quiet, or they're crying or screaming. If it's uncontrollable weeping, what is their emotional volatility, where they're happy, smiling, calm, or they're neutral, or expressionless, or they're concerned, sad, scared, or their eyes teary, or are they anxious or crying. You have a scoring system for this, but it's one more idea for pre-anesthetic. So to be able to actually see the anxiety effects, where they're alert or looking around, where they're looking around, where they're very concerned, where they're crying or they're panicking, and how they're interacting with their folks, where they're playing, where they're focusing on their parents, where they're sitting or inactive, or is there anything that they're doing that is right for their age, or they're looking for their parents as a point of focus, they're looking at their parents quietly and they don't seek more contact, or they're keeping their distance. That's something that you need to keep in mind, and each of these things. So it will be divided by the amount of items at their value, and then we'll by 5 and multiply per 100. If the score is less than 30, it's a very low score. It's a risky score to apply in our day-to-day life, but it's a good score to have as a base. Okay, what can we look for when I want to assess anxiety in children? And so about the autistic situation, this is they have a hard time interacting socially. It's very prevalent for an increase. It's an increase in 175% from 2016 really into 2010. And yes, so 18.5 children every 1,000. So this is very prevalent. It's seen as a change in the criteria. So there's also the knowledge of the population. So knowledge on the part of the population. So it's something that became more common to suspect. So that's why it's diagnosed a bit more. So the perioperational period is those children because they respond to stimuli, sound, tact. So they're more sensitive to our environment, which is a completely hostile environment to a kid. So a hostile environment, it has a trigger, in effect, and it causes anxiety in most of these patients. So kids are a population that we need to keep in mind. We need to treat them as best as we can. Some non-pharmaceutical actions we can take to improve things for these kids is to treat it this first kids a day or as early as you can. Reduce their staying time for these kids. Nowadays we have the badges for autistic patients, so they go ahead. They go ahead of everybody else. It's the right thing to do. As quiet as possible in the room. So there's a large number of people try to avoid it during a lot of people. So only the right amount of people needed for the operation, and a more experienced anesthesiologist that knows how it has acted with this population before. So the comparison to use of oral midazolam, more ketamines for the pre-anesthesia on autistic populations. So it's a double-blind, randomized trial. And the primary goal was to compare the degree of sedation amongst patients within both groups. Midazolam 0.5 milligrams per kilo plus 15 milligrams, or oral midazolam 0.5 milligrams per kilo plus ketamine as 3 milligrams per kilo. Most. So for secondary effects, we established as of hypertension for venous access, because despite having the induction is not inhalatory, it was not breath. So after pre-anesthesia, we had the main access and not inhalatory anesthesia. So I'm awake, and the occurrence are not of adverse events, nausea and vomiting. So these were separated 32 patients per group, and that's why we had a capacity of detection of 80% and 5% tolerance to errors, and exclusion criteria for patients with immunity of 2 to 59 years of age. So not just kids, but had a prior diagnosis of the autistic spectrum. They need to be ASA 2, and they needed free anesthesia for lymphatological procedures, 2 hospital in Goiânia. Non-inclusion criteria where a patient had a difficulty airways, the kidney dysfunction, or any adverse effect, and the exclusion criteria is when they had incorrect ingestion or vomiting or surgical complications from bleeding, and this could be recuperated for the operation. So the patients were medicated in the nurse office. So after my situation, so only the nurse knew what was the medication that was being applied, and the dosage was in the right and the real weight. So the degree was assessed by the anesthesiologist. So we can go to group 1 which would be vaccine 1 or 2 or the group 2. That's then higher or equal to 3. So the patients were separated into tutors in the surgical center. The reaction to the vascular access was dichotomized, with or without the need for contention. And general anesthesia was performed the same way for every patient. Fentanyl 2 micrograms per kilo, propofol 3 micrograms per kilo, acetaminophen 0.15 micrograms per kilo, and the patients stayed with fluorine, and increase 0.5% according to the parameters if there's any sort of escape. And if it reached higher than 4%, we had the fentanyl bolus 1 microgram per kilo. All the patients were medicated with Divarone and Nazacrone, and the time for wake was measured in minutes, in the moment of interruption, administration to intubation. Patients stayed on EPA, a basal state and RPA, and we watch for adverse events, spasms, diarrhea, nausea and vomiting, and it was ambulatorial stay. So the results, 64 patients were eligible. 64 actually were randomized and allocated. The midazolam plus ketamine, 4 patients refused to take the medication. They left the study, and within a follow-up, all of them managed to be analyzed. So 32 or midazolam and 28 on the association of midazolam with ketamine S. And the main goal, they saw that there was a significant difference between the groups, one listed at 0.02, the dichotomic 2.6% patients of patients on midazolam present Ramsay higher or equal to 3, and 30 Ramsay 2, and higher than 3 was observed in 50% of patients. See, the trust index is pretty good. And the secondary goals, getting vein access was much easier in the midazolam plus ketamine group, P equals 0.01. And the relative frequency of contention was lesser on group 1 of decision than midazolam group. And for ketamine made it easier to access the veins when 64% of patients with RR 2.05. Also, we had no difference in the waking time of patients. All patients had SRPA with 60 minutes, and they were released from the hospital in 2 hours. So you can see the curve has no difference and adverse effects. And you can see that practically there was no difference between the groups. So the conclusion of a study is that doesn't with ketamine S promotes a more deep sedation that is efficient, and it makes it easier vein access. Does not alter the waking time or the release time. There's no adverse effects, and with that, there is a contribution for the improvement of anesthetic management in this population. So finish this, I think a few messages you can take home is that prescribing anesthesia not your routine. So kids, not just because they're kids, are going to get pre-anesthetic medication, but when it's necessary, it must not be forced because the collateral effects of an anxious child are very bad. We not have the ideal, but this must be done for pancreas patient and for surgical procedures patients that are on the spectrum or any sort of neuropsychological alteration must have an individualized approach and must avoid stress as much as possible. So this population goes to the hospital a lot, and the association with that with KMNS is safe and it's beneficial. There is more deep sedation in this case. So that's it. References and book, and that's it for me. Thank you. Thank you, Bruna, for your participation. It's very good. A very good explanation, and really explain in a very practical manner the use of the pre-anesthetic communication on pediatric anesthesia, and as well as contextualizing the randomized clinical study which was connected to this, and also the editorial that was published citing this study and other studies also published on the list as was commented before. A few considerations regarding the pre-anesthetic medication as well as the study is that really, as you said very well, for us that work on clinical anesthesia, for kids is we're always doubting what are we going to work for anesthesia, and there's changes from hospital to hospital. So within the clinics themselves, in the institute, Children's Institute, we have a way to anesthesia. It changes completely. It's important that we know what is the actual routine for administering pre-anesthetic medication. We know that most hospitals will not have very frequently a pre-critical center. We're monitoring. It's simply too expensive. If they can have all the medication for anesthesia, but sadly we don't see this. Well, the anesthesia, which is midazolam, it's extremely safe. So for us, it's very common we work on midazolam on most patients. But we need to keep in mind the counterindications of midazolam. That is the reason for the discussion. But you gotta remember that there are counterindications. We need serious counterindications. Not make midazolam just because, not use midazolam just because it's a kid. We need to remember that depending on the situation, and there's no way that anesthetic medication or the child is already close to you and it's a more serious issue. The child is anxious, but we can get lucky if we have vein access, so we can have free anesthetic access, but with anesthesia at the same time. So you will improve the application a lot. So when we think about association to ketamines, it is a very interesting association with these kids. I have a hard time pre-medicating these kids, and we know that these kids that have psychological alterations like autism, they're very difficult to sedate, and we have a hard time helping on the induction. They struggle a lot when it comes to induction, and depending on the child, it may be dangerous for them as well as for the people that are involving in the pre-operational assistance. So this association of midazolam as well as ketamines is very interesting, and the studies for our colleagues showed that it was a good thing for management of anxiety, pre-operational anxiety, as well as the vein access. We had the induction, the IV access for these kids. So it's a good option for situations where we have the kids have a hard time when it comes to helping on pre-anesthetic induction. And really, when we think about this combination of midazolam and ketamines, it's the best. I think that there's no other combination that will help you as much as midazolam and ketamine because it's a quick effect. They can do this through oral access. So it's very interesting for us to have this association. We have evidence that this shows that this is useful. And this morning I was talking to my friends from the hospital of Philadelphia, and I asked them whether they have this practice of using midazolam with ketamines. And I asked them first where I have a practice of accessing ketamines orally. They said that in their hospital in Philadelphia, and the centers and the ambulatory patients, as well as the general hospital, they have 24 rooms in the general hospital. The more utilized medication was midazolam orally, so they use a lot of midazolam orally, and the second option that they use the most is intranasal midazolam. You know that in Brazil, we use midazolam a lot. Majorly, it's not easy to access intranasally, so they're going to be less collaborative for your nasal access, depending on the situation. So ketamine is the third option for them orally. And without asking, they informed me that in a few situations, for instance, autism, they associate midazolam with ketamines with the doses that were tested on the manuscript that was published, that was discussed in Goiânia. And so it's a practice that is consolidated for this sort of patient because it improves quality of induction quite a bit. And they say that they don't have it as a clinical practice. They almost don't use alpha-2 agonists, almost. So have a few practices. And again, it's an easy way to administer this. And depending on the situation, it's very difficult because they all need at least 40 minutes to have this. And as you can see, dexmedetomidine, nasal dexmedetomidine, they'll have a hard time. It's difficult to have the atomizer because if you don't have the atomizer, the child will simply swallow dexmedetomidine, and we know the bioavailability orally it's very low, so it must not be evaporated. Oral dexmedetomidine is the same thing as giving a placebo. It's lesser than 15%, so it's not great. So ketamine has a very ability that is increased dosage quite a lot, up to 6 milligrams per kilo. It'll have an effect. So with dexmedetomidine, you're going to be able to do this with the limit of the dosage because I only have 200 micrograms for your day. You can't have a very high dosage orally. So we have a question here in the chat for Eric. Eric also is the editor of the magazine. Eric, thank you for the question. What are the possible advantages and disadvantages, in your opinion, of the entrance of parents and the surgery room when they're going to put under? So what about the new technologies we have? So what is your opinion, Bruna? So we have a difference on the Institute. The parents enter the surgical room and the hospital, children's hospital, don't enter the hospital most of the time. And I think that when it's managed to interact with children, they have a good emotional state. It can be a positive thing. Be good for kids because it's safe. They have their parents next to them and ends up becoming an environment that is less hostile. But the disadvantage is that generally is for the father, parents. They complain, saying the kids they don't like seeing their child being put under. A lot of them cry, they're anxious. So they have this dichotomy. And so for kids, it is positive to have the parents let them, but for the parents, it's very bad. Some of them don't feel great on seeing their kids going through that. So there are pros and cons. So when parents don't enter, I think that depends on whether or not you'll be able to get trust for the kids. So we'll be able to interact more with the child, the anesthesiologist with the child. So for them to be able to participate in the surgical center, explain to them that it doesn't hurt when it's possible for them to understand. So I don't see a lot of differences when it comes to trauma or these kids think that it's unpleasant. I think it's more about the parents themselves. The parents complain. They don't wanna see their kid being put under anesthesia. So when it comes to technology, I have not had contact and experiences. So I know that the technologies, even cell phone technology, helps a lot. We had the apps. So we have the app that was developed in Brazil. Shows the experience of the new surgical center is positive when they don't have access to this. It's going to be shown to them. It's like a sort of game. What are the surgical activities like? So they put on their clothes, then they go to the hospital. What is the outfit at the surgical center? What is monitoring like? This is done in a sort of gamified way, if that makes sense. And it's that we can use VR, for instance. VR will be a benefit for sure. What do you think,
Eu acho a
Vinicius?
mesma coisa, eu acho que
I
realmente
think that it's
quando pensando nessa situação dos pais, eu
the
também
thinking
eu,
about the situation for the
eu também
parents.
tenho
I
esse
have both experience. I've had both experiences because on the HC I have the parents and
a
the
gente não tem e
and in
realmente
the
eu vejo
hospital we do not allow the access of the
a
parents. I
mesma
don't
coisa,
see
né,
that there's a lot of
na maioria das
change.
vezes a mesma quantidade de
Whether
medicação,
they think we use the same amount of medication, pre-anesthetic and medication when the parents are in, whether they're in or not. So the way that the child deals with this, with anesthesia, this comes from literature as well. It's there's a conflict. And it doesn't seem to be a disadvantage or an advantage. So he said something very important that we have our parents in the surgery room. What we need to do is that we gotta explain very well to the parents what's going to happen, what their kids being put under anesthesia, what's going to, when I talk to them, you're going to go in, you're going to see your child. Your child will be breathing differently. They may make a different noise. Maybe their eyes will roll back. They may become agitated. They may be able to want to get away from the mask, but they're just not hurt. It's normal. So when I say, okay, your child is asleep, okay, I say, okay, anesthesia only works when you give them, when you kiss your child, and then they'll kiss their child, and then they'll ask them to leave. I always say that to them because if not, it's really frightening for a parent to see their child because especially if it's through the mask. So when it comes to the VR equipment, I think it's very interesting. I'm very much in favor. Sadly, we have a hard time with the pricing. It improves the price for the glasses, VR glasses. The price is a lot better, but the actual process is very expensive. So, but simple things like anesthesia, we've seen this several times. We've seen that so we already have evidence showing that this diminishes the anxiety for children, but we need to have low clinical applicability. So when everything is rushed, there's a very large agenda. So we end up not being able to apply this. So I'm very much in favor, even though we have very little clinical practice for this type of device. So that's what I remember. Can you hear me? Yeah. Well, first off, congrats on your presentation. It's great. Congratulations, Mrs. So I have very two quick questions, especially regarding this patient or combative patients, especially adults. they have some sort of autistic spectrum, and so I end up very agitated. So a lot of the time in representation, we need to have intramuscular. When it comes to ketamines, the recommendation and whenever it's associated to the drug, if there's any higher risk. So ketamines that are chosen.
Associado ao midazolam, tá? Então os riscos e se a gente deve fazer algum
drug, I mean, to have a joint administration of any sort of drug. And the second matter is regarding dexmedetomidine that you cited their limitations. And Porto Alegre, it's very much used dexmedetomidine, even without the applicator. Some colleagues are experienced using this, and they mention good results, especially with bioavailability, especially on the sensational dexmedetomidine. And the bradycardic, like dexmedetomidine, the use of free anesthesia. Some kids, I had the chance of doing this, and when we put these kids on monitoring, some bradycardia established a significant bradycardia, but high repercussions. It's scary because they're kids have more elevated frequency. Those are missed questions for you and for Vinicius. Yeah, Andre, generally we always have atropine together with ketamine, intramuscular. It is, say that should be done together, especially intramuscular, so we end up having higher doses, 10 milligrams per kilo. So we end up doing this in a very tall teenager, and we couldn't hold him down and start struggling. So we work with diatramine. So this is that doesn't bother when it comes to intubation. So it's important to use this no matter breathing. So with ketamine and dexmedetomidine, it's something that in my service, it's something that I always do. I don't do this a lot in my practice, but what I observe in dexmedetomidine intraoperation is that there are not a lot of high repercussions on adults. It's not very much pronounced, and bradycardia and hypertension occurs less in kids. So it's safe, but because of the intranasal, intramuscular, other things, they're not described in the book.
E acho que é isso, assim, acho que a associação da ketamina com a dexmedetomidina, ela é interessante.
So it is interesting, and there are not enough studies to be able to say it can be done with monitoring or not. That is my opinion. What do you think, Vinicius?
Não, também concordo, concordo com você.
I agree.
É muito relevante.
That's very relevant, and when it comes to the use on a small child, I don't see any issues. People discuss whether there are counterindications for using biotropine for a child. It makes no difference. We need to be worried about anticholinergics on the elderly, patients that have a sort of issue. So it makes no difference. So we have very little experience, Andre. Preanesthetic patient. I've used dexmedetomidine a lot and intranasally, and 4 micrograms per kilo on autistic children. You can't even speak to the child. Ambulatorial center, and we did not have for anesthesia, so we had to have routine sedation and dexmedetomidine, which was only first, like, it was still expensive. You needed to have the applicator. It was a public service, and it's still cheaper. In that case, it's cheaper. And as would be the pre-anesthesia medication. So associating ketamine at no advantage. So have an effect that the anesthesia medication that are accommodated. And then recently, and I watched on the practice a very interesting discussion next time being of a child that knows the most about this in the world is Kira Mason. She's a pediatric anesthesiologist, and she is extremely very high specialist in sedation for procedures in the surgical center. We don't want to be where they are anymore. And when I went to R3 in 2009, I had the possibility of getting to know her when I spent some time at Boston Children's Hospital, and back then, we were stated he was one of the pioneers using dexmedetomidine for CAT scans and MRIs. And she says that associating dexmedetomidine with ketamines was very interesting, and it's I really like it a lot. It's something that there is an intravenous association, but Jane prefers to have dexmedetomidine depending on the situation to associate. It's better with a single type sedation for procedures, but intravenous. So they're not used to intramuscular. And when it comes to reverse effects, we see very little rough breathing intravenously. So I have very little practice in anesthetic medication due to a lack of applicators. I don't see this issues very frequently, but since we use very high doses of 2 micrograms per kilo in 20 minutes, I treated breathing. I had to take some hypertension through surgery. It belongs to another group type of, it was dexmedetomidine, and that's why I had to move it. But yet they have this effect, they have less rough breathing, but it can happen. That's why we need to keep an eye on these kids, because it ends up still being quite safe for this population. So we have 2 more questions here from Malito. Congrats, congrats for the presentation. How do you sort various advantages of stationary use routine of pre-anesthesia? What are these resistances like? The team, like knowledge, their parents' fear. What do you think? Yeah, it's very difficult, and it varies from hospital to hospital. So the children's hospitals, it's something that is more well pre-established. You know how to do this, and a pre-anesthesia room for the general hospitals, like most of the hospitals, it's not very easy.
Acho que varia de hospital para hospital, mas tudo tem que ser explicado, né? Então, se você for fazer,
it needs to explain. Everything needs to be explained.
De hospital que não tenha
monitorização, a hospital that has no monitoring.
Como referência, então a enfermeira tem que estar sabendo bem.
So the nurse needs to be in the know. Floor nurse, so there needs to be signs for the parents. And I think that trying to institutionalize the hospital protocols, but the whole team need to be speaking the same language, ways to know what's going on at the right time. I think that's it. So when the hospital, you have a very difficult time implanting. So it's the nursing is used to. They actually think it's very You don't need to prescribe medication because you have a lot of trust. So we'd say, okay, most important thing is when we discuss the quality of safety and pediatric anesthesia, remembering that most hospitals that have these surgeries, there are general hospitals. We have to develop within these hospitals procedures, standardized procedures. So it's very important. Developing protocols is very important. So what is the dosage? We need to think about that. Develop. It's very important practice. And one question from Gabriel Lassette, I think Gabriel is from Mexico on the National Institute of Pediatrics in Mexico for my colleague. And congratulations for the discussion. I says then they're a hospital and we don't use intranasal because the autistic patients, they become very agitated. They become very, as a side effect in Daslon, they get very agitated, very excited. Also, dexmedetomidine orally, but he said it is interesting that your papers discuss medication and these patients. I don't know why. What is HPA? Shows that it is these results are interesting. So it shows that Gabriel, when we have availability for these medications, especially dexmedetomidine, and if it is available for these patients with the applicator, the applicator for nose applicator, you need to have the contribution of the patient. This patient is if it's a very combative patient, they will not accept nasal application. So you'll need to have intramuscular therapy due to a matter of safety. You must have of the teenager due to matters of safety. You give an example of a child that I added anesthesia to a few years ago, 13 years old. The operation was very late. It is a Nigerian child, didn't only understood what the parents said. They spoke with them in English or in a local language, did not understand Portuguese. Dark-skinned child with a sleep apnea and she had very serious autism that seemed that they were hitting themselves and attacked the caretakers a lot. So see the characteristics, despite not being typical. And for his child, and very calmly, they got the vein access, and there were no issues. An inhalatory induction for a teenager, large teenager, 60 kilos, sleep apnea, and a hard time flying through the IV, so it was safer for the father. The father helped a lot and really helped us with induction, intramuscular induction in this case. Also remember dexmedetomidine, ketamine, and midazolam. Yes, but so it's something that will be there. But the child maybe it's not very nice, but for others it's not so great if you have oral access or full muscular applications. So after oral midazolam, you get to Brazil, we basically abolished intranasal midazolam. It's not very good. Even nephrologists, they don't use it anymore because there is a risk of hemorrhages. So not even they use this anymore, intranasal. And one final comment before we finish this. In European countries, we have oxazoline, which is also midazolam, which has more quick absorption. The availability definitely we have in Brazil. It tastes like orange, not like strawberry. We do here and manage to manipulate the molecule to remove that bitter taste. So don't let the kids taste the syrup because it's very bitter. Will not want to get so ask them to drink all the midazolam once because trick them into drinking but the aftertaste is bad if they taste it. It's very bad at this lab and Europe managed to modify this orally that has better availability. The initial effect is quicker than we have here in Brazil. So, sadly, we still have no forecast of this getting here to Brazil. So, we answered all the questions, and well, I would like to thank you all once again for your presentation. Bruna, thank you, and also for our discussion, and thank the Brazilian Journal of Anesthesiology, and Andre for the invitation to drive and discuss with you this subject. I will pass the floor to Andre. Thank you, Vinicius. Congratulations once again. Bruno, Vinicius, great discussions, high-level discussions are very relevant. And I once again reinforce our call for papers for our special edition this year for pediatric anesthesia. Within the focus, so here in the chat, colleagues in TD access link for our all-to articles and the site. Well, the networks will share several informations. The submission period, the deadline period will go to the end of this year's specific date. It'll be shared with the colleagues, and we have our Brazilian colleagues and we have our colleagues the whole world over there interested in anesthesia and these work. So it'll be info for next year. So thank you for your attention, and we'll see you next webinar on August 31st. Thank you. Good evening.
Boa noite, obrigada.
Até mais.